Is this the right, or this is the presenter?
Your screen isn't shared right now.
My screen isn't shared right now. So I should say share screen. Okay. No, not yet. So let's see. You see it right now, ladies and gentlemen?
Yes, I see it right now. In like edit mode.
Edit mode. So
you just have to click the present button.
I am clicking the present button. Yes.
Okay. We're seeing. Yeah, you need to change the display settings. Yep. Swap.
Okay.
Perfect.
Okay, so before I go into our cases, we just start to put information up. So the team here at the Bio Institute of Stanford here, we put together a Retina Innovation Summit. Initially, we were scheduled to have a live meeting, but now we move it to virtual, and there will be 3 different virtual meetings in August, October, and December. The day are here. If you go to retinainnovationsummit.com, you will see the information there. And the best thing about this is that we have decided that it will be a complimentary registration, so colleagues from around the globe can join us in this aspect from there, and we will present different aspects of things. So if you have time, join us. And if you forget, just go to retinainnovationsummit.com and we'll be set. Okay, so this case here, I think we have Dr. Chu in here, and I think we have Dr. Kidar and Dr. Foster as well for this aspect. So let's drive with this. So I'm now going to show you, I believe, 2 cases because I know I'm running out of time here. So let's start with the first case here. This case is a 13-year-old Vietnamese Australian girl whose 2 months prior to presentation, she developed a flu-like illness that lasting about 3 weeks with red left eye. She came to us with no fever, chill, cough, rash, or ulcer, but she does have some joint pain. Again, and this is a case that I share with Dr. Peter McCluskey from Sydney, Australia here. On examination, visual acuity is about 20/30 and 2100. The intersegment are shown as shut. She does have significant anterior cell, 4+ cell. She has multi-fat KPs. She has IOP of about 18. And the vitreous also have some cell there as well. And this is her finding of the posterior segment. Okay, and right eye, left eye. Any thoughts so far? Dr. Hiên, you wanted to try? Okay, so how about we try to narrow it down? Okay, so this is the fundus of that eye, right eye there. So this is a 13-year-old child, right? So David or Sanjay or Dr. Foster, any question, just please stop me and I'll stop. Is
that a peripheral retina view, like inferiorly or something?
Yes, that's the inferior view where you see a lot of the vitreous clump that you see there.
So that's snowballs,
yes.
Snow banking probably in the periphery.
Yes, snow banking is coming up. Yes.
Snow banking. So that's intermediate uveitis.
Intermediate uveitis with a lot of AC cells, okay, yeah. So far. And Natasha, what's the difference between intermediate uveitis and pars planitis?
So pars planitis is a diagnosis of exclusion.
Exactly. So when you already rule out other aspect already, you would call it a pars planitis. So here, Dr. David chooses called intermediate uveitis because we don't know yet. We have the case here. This is the optic nerve showing that the fact that it is a swelling and changes in there from this aspect. There and the foveal center preserved in this aspect from there, no significant macular edema. So you have asked for, you have suggested, let's suggest some of the description here. So now if you have to bet before I show you what the diagnosis is, what would be the most likely case in this 14 years old Vietnamese Australian girl? Who is this a case of intimate uveitis and then eventually go into prostatitis because we don't have a cause, or what would this be?
Syphilis?
Say it again.
Syphilis?
Syphilis. So a case of syphilis. So syphilis certainly can manifest with anything. So that's fine. We can definitely consider that in the diagnosis, right? So here's what the investigation show from this aspect from here. So normal electrolyte, Z-ray is just slightly, not really elevated there, but just slightly over 45. CLP is mildly elevated. And as UA is normal, the ANCA is negative. The ACE is 36, which is normal. Testing for syphilis, if FDA was negative, non-reactive, the mental skin testing was also negative.
Quan, does this child have a pet kitten?
A kitten, you say, Dr. Foster?
Yes.
No. No, and Dr. Foster asked because as we discussed this morning, we say that it would be any test possible for any type of infections like toxo or cara, or for example, Bartonella as all. So this patient did not have that. Now, one of the tests were tested because she's a young girl with uveitis, so the ANA came back to be 1 to 640. Okay, so that's elevated, that's high with this aspect. So what should we do at this moment? So this patient subsequently was, because of this finding, because of her age group, and because of her symptom of joint disease, even though it's still early, she was then managed, given an active disease, diagnosed with JIA-associated uveitis, and that was her regimen of treatment. Any comments on whether or not the treatment is appropriate, or the diagnosis is appropriate, or what other things that we can consider?
Well, it's certainly atypical for JIA. This is not a typical JIA kind of case.
Okay, so it's outside of the rim of that aspect from there, because you remember that she was told that I described her that she has character precipitate on the eye, correct? On the cornea. So definitely.
So you said what kind of joint manifestation?
She has mild arthralgia, so she has a little bit of knee pain and elbow pain.
So sarcoid in children present as arthralgia quite often, and that should be kept in mind. Even though the ACE is normal, I would scan for any possible site for biopsy.
Definitely, that is very much a possibility, and definitely that's very appropriate, because as we mentioned, the ACE and the lysozyme may not always be specific in here. So any different management for this type regimen for this patient, we just heard from Dr. Chu about what other thing to move forward with this aspect from there. So the patient subsequently also show other evidence as well. So because of that, of the potential that thinking that David was thinking, we have a chest X-ray that show no active disease. Now we have an MRI of the brain that show enhancement of the optic nerve also, because as you can see, the optic nerve was quite hyperemic in this aspect. Fluorescein angiography, which I did not show, also show leakage of the optic nerve. So both optic nerves show inflammation here.
Another item on intermediate uveitis differential is Lyme disease. And was there any history of exposure, tick bites?
Yes, so that's definitely appropriate in here, David, and definitely is correct in there. This patient did not have any history of tick bite. The ocular manifestation of Lyme can definitely be, as you described, with anterior uveitis like this with optic nerve, but a very common, or at least the one that we have seen that affect the posterior segment would be any of our residents know, Price or Natasha? What is the ocular manifestation or the retinal manifestation of Lyme? It would be, no, it would be exudative retinal detachment. So those are the cases that have been presented and discussed in there. So it would be exudative RD that are associated with Lyme. So if you have Lyme like that, that's definitely on the thing in there. And in addition to what Dr. Chu has mentioned about the presentation of that aspect here. So in this particular case, does anyone want to ask anything else regarding the testing or anything else that I missed? Okay.
Well, she's young for MS, but did she have any white matter lesions or?
No, she did not have white matter lesion and MRI, but also think back again, the anterior segment examination showed that there were quite a bit of active cells, right? 3 or 4 bloods or so, and presence of KPs. Okay.
Herpes?
I'm sorry, herpes. So herpes, that is definitely one of the masquerade. And Dr. Foster mentioned this morning, it could be anything. So it could be, sometimes it could be KPs, or sometimes it's not. Usually tend to be more unilateral, but certainly bilateral as possible. So in this particular case, here comes the trick coming here. So far, we have seen anything and something seems to be consistent. Now, when she, about a week later after with treatment, this is what coming back, okay? So this is a test for her. Even though her mental testing was negative, her quantiferin goal was quite strongly positive for this aspect from there. And that's something that we know takes some time to come back, and we start treating this aspect. So at this moment, we have a problem, because this problem right now is what exactly does this patient have? Does she have an infectious etiology and touch treating with this that manifests only in the eye, or does she have like a underlying systemic disease, and the infectious, in this case TB, is something that just out of the ordinary and not very clear. So at this moment, the management team discontinued all systemic therapy and sought additional opinion after no significant improvement was noted in here. Okay, so what is happening on this case, and what very much is the correct diagnosis here of this part? Is this a case where we obtain a lot of laboratory workup and then maybe it's clouding? Is it possible that the generation of the some of the test results could be the problem here that sort of like blindfold us into considering certain diagnosis? So in general, the point here would be that the clinical assessment is the basis of diagnosis in uveitis and need to be quite carefully done. So we did everything we could here. We conduct a careful history, and we review the system. We also did a complete ocular examination, but the term of the disease is quite difficult in this case, because even though we try to be targeted, we still cannot be really clear in this case initially. And the question here would be, was the ANA useful or important or not in this case? We did it because it's a uveitis in a young girl, so we want to find out if indeed that they have any type of uveitis, because those with positive ANA is to be consumed because of the poor prognosis. On the other hand, when should we order an ANA in this part from here? So when should we order an ANA? In general, I think many of us will agree that the child in the first decade would entail uveitis. Definitely we should do that, because we want to make sure we be careful with the chronic uveitis in young girl that we can do. But we cannot diagnose anterior uveitis unless examine the fundus, which we look at here. We find out panuveitis, and not just anterior uveitis, and probably optic neuropathy. That's what we ordered it. And other cases we should look at for the ANA is listed there. For example, posterior or panuveitis with prominent retinal vasculitis, especially in the posterior segment. So I chose to present this case because I thought that really raised a diagnostic challenge for us and also in management as well. I believe, as Dr. Foster mentioned and David mentioned, this patient probably does not have JIA-associated uveitis. Does anyone feel differently? Now, Dr. Chu mentioned that perhaps this could also be a case of sarcoid for this aspect from here. Would that be a case here or not? Or sometimes called a Blau syndrome that may look like sarcoid in young children for this aspect from there. Does the ANA mean anything much here? So there's no clinical evidence to suggest lupus in this case, correct? Because the patient doesn't have any other findings with this aspect from there. So how do you think we should now move forward to treat this patient?
Well, you started the meds, you started oral prednisone. What was the response?
The response is that the patient did not really improve very much with the aspect. Given the high dose of the prednisone, it still did not completely resolve. The cells.
But it responded?
It responded. Some it responded. So I would say partially responded.
Mm.
So in this case, we will, when we look at that result. So, and I'm going to present what we did and see if people disagree. So this is what happened. We believe that given the situation, there is likely to be ocular TB that's happening in this patient. And therefore, we actually suggest, and the patient went on and did get better for this thing, that the patient get an anti-TB therapy, so ATT treated for this one. And it was not without much deliberation because the patient is young and we don't want to commit it to it. But given the fact that she has that aspect from there, and given the fact that she has risk factor come from certain endemic area of the world, we thought that was appropriate. So we follow the ATT treatment, and then we also combine, and we do right now with anti-inflammatory, continue with that as well. So I certainly like to seek the thought from Dr. Foster, David, and Sanjay there to see if where could I have done things a little bit differently, and how should we approach it again if I were to see another case.
I think with the quantiferin being positive and the history of where the child came from, that kind of treating as that is probably appropriate, but this would be kind of unusual for, of course, TB can look any way, but just clinically speaking, just the clinical presentations with the eyes, the bilateral nature of it, the joint involvement, I feel that probably sarcoid is higher up on a list, and having to treat the TB as treating TB as the primary source of this condition, I don't know that I would pursue it as that. I think as a prophylactic treatment, that's probably what I may have done, but especially in light of the fact when you started treating, there was already partial response without the anti-TB therapy on it, right?
Sure.
So generally with the TB, you give steroid, it doesn't get better at all.
Initially, some of the parts, so the optic nerve did not get better, but the AC cell did improve somewhat with this aspect. So this come a challenging thing. This patient ended up receiving treatment for about 6 months or so, which is in the way they use the latent protocol there. And they did ask us, and we go back and forth to say with that, because given the quantiferin and given an active side organ, we thought that this is a potentially of benefit, but certainly I am full agreement with you as well. There's different controversial aspect here, and that's the reason why I thought this would be a case in here. But the headline here is that this ANA can come back positive. That drove a lot of people to do that because it's relatively high, and it could be that patient with certain type of infection may have like a falsely elevated ANA, for example, with this in some way with that. So that was the case here. Now, let me move on to the next case. Any other comments from anyone else?
Another comment, like when I, when you did a chest X-ray was negative, meaning no lesion seen. For when I tried to survey for sarcoid, CT may be superior if you looking for it in the chest, but also don't forget the OTEC gallium scan. That may be able to tell you like other areas that may potentially have some sort of inflammatory process going on. For example, if there's a lacrimal gland that's inflamed, the salivary gland, it'll show up on a gallium, and then those are relatively easy to access for biopsy. With the BLAU, it's more really of a, if there's no family history, it probably isn't, but I think you can biopsy the joint, because it's more synovitis, not so much arthritis. So you can biopsy the synum, and may show granulomatous inflammation, which may help you with the diagnosis.
No, I fully agree with that. So a patient actually, I didn't show, the patient actually have a CT done, because before at part of the ID evaluation with the patient, they want to make sure also to see that the chest was completely clear here. So it was thought to be, if the case in here would be mainly ocular TB in this aspect from there. So that's the reason why we consider that aspect from there. But Dr. David, you raised a very good point, and definitely, definitely we have to consider that at the way that we considered moving forward with treatment with the patient. But she did work out to have a, I did not do a gallium scan, but the chest CT was relatively clear, well, not just relatively, it was completely clear in this patient in there. But as you mentioned, there could be other organs that perhaps as well. Okay, any other comments?
Quan, do you know, was the ANA repeated? I mean, I just wonder sometimes when we get abnormal testing that doesn't really fit with what we think, whether there's a lab error or a mix-up in the sample or something like that, which could have given you the high ANA that may be confusing the picture.
Yes, Sanjay, excellent point. Indeed, it was, and I didn't show that either. So after the patient just started treating like that, about like 2 weeks later, 3 weeks later, I did test it, and it did drop down. It dropped down eventually to like about 1 to 80 or something like that. So it's definitely dropped down to the more non-specific level. Right. So you're correct. The ANA was thought to be out of the not necessarily truly high elevating this patient. That's an excellent point too, and that thing can change in some diseases as well. Okay, so let me move on to the next case for you here. Okay, so this case is somewhat more challenging. Okay, ladies and gentlemen, here. So this is a 33-year-old man from India who presented with painted progressive loss of vision in both eyes for 5 days. No other oculist complained with this aspect here. He presented to us with continuous fever lasting for about a week, associated with joint pain prior to the onset of the visual complaint. So some non-specific joint pain and then have visual loss. He also have headaches, also localized in the front part of the head and relieved with NSAID, non-steroidal. No history of chill or joint pain when he complained with this aspect. And there just a muscle ache but no joint pain. No history of diabetes or hypertension. He was first presented as a community private hospital whereby because he was told that he has inflammation. So easy thing is that the local ophthalmologist give him a subtenon injection of dexamethasone from there. And the inflammation did not improve, and he was just referred to the tertiary care center for the further management here. On examination, this is him. So the tear segments show stable intraocular pressure. For Bresso visual acuity, however, was quite poor, counting finger in both eyes. So counting finger right eye, counting finger left eye, with the pupil not reacting so well as like that. Anytime you want to stop, just please stop me and I will stop in there. Okay, so this is the finding in the fundus of the right eye. And there's some abnormality along the vessel here. Does anyone see anything that is outrageously abnormal?
The patient has an arteritis.
Yes, definitely. The patient have an arteritis, as Dr. Foster mentioned in there, from there. Anything else? You even see very thin effect in this aspect in a certain pattern, because you can see the vessel sort of like narrow a lot.
There's venous engorgement.
Yes. Dr. Ngọc, do you see anything on your view that of suspicious? Okay. Here's another area as well too. Okay, so this is the right eye. There's narrowing of the retinal artery, and there's also, I don't know if you can see it, there's small amount with hemorrhages that we've seen. There's also the very, very fine the yellow arrow there to show that there's intraretinal wide lesion along the arterioles and venule of the perimacular vascular network that we see in here. So you see, in addition to the narrowing of the vessel, you see a few retinal hemorrhages. You also see the wide lesion along that path as well. Okay, so this is the and the wide arrow just point out to you some of the little heme that you see. Okay, now this is the left eye showing something what's similar as well to wide lesion along the fine arterial and venous of the perivascular network that we see. Okay, and Dr. Foster pointed out there is evidence of the vascular inflammation of this aspect here, the vasculitis without any sheathing of that. So anyone think of anything, any other question? So his systemic examination, that's just obviously because given how sick this patient is, visual acuity down to counting finger in both eyes, we're obviously concerned to make sure that there's no gross systemic finding. So the pulse was 90, it's reasonable, blood pressure fine. So far, cardiovascular system, respiratory system, everything seems to be normal in this aspect. So I'm presenting right now a case of a young man, 33 years old man, with sudden painless progressive loss of vision in both eyes for 5 days, fever associated with myalgia, visual acuity, funduscopic examination, visual acuity is counting finger in both eyes. Fundus examination point out will show, what Dr. Foster showed, indicated focal narrowing of the retinal artery and retinal arteriole and fine vessel along the arteriole. So I'm giving you a big hint now. For colleagues who are from the Middle East and from the part of the subcontinent, this may be something that you may have seen quite often here. Okay, so the provisional diagnosis at this case is bilateral retinal vasculitis, as pointed out, with macular involvement of unclear etiology. So in this patient, no history of cough or loss of appetite, no history of TB or TB contact, no history of oral ulcer, genital ulcer, or skin lesion, and no history of blood transfusion. So far, not much in terms of anything that we suspect. Okay, now let's so far with this. Now you probably would like to say, okay, what will happen to some of the fluorescein aspect that we see so far? This is what we see on the fluorescein angiography on the right. And when you look at this aspect from there, you see just enough of the perivascular leakage and blurriness of there, and you see the focal narrowing of this aspect that is arteritis that is which mentioned before by Dr. Foster there. Okay. That's the little bit later of the optic nerve. Now this is the OCT of the patient, very much loss of the tissue outside here. Because the patient have the vasculitis that we see, all those small amount, the careful examination rule out any type of systemic vasculitis in here, because we obviously worry about systemic vasculitis leading to this. So after baseline investigation, because there was no evidence of any other thing, any infection, the patient was given 3 doses of IV methylprednisolone in a way as empiric treatment, because the team did not find any other way to control and was hoping that this was a significant type of inflammation that we be able to hopefully try to control right away without specific cause yet, because there was no clear infection. And further investigation was then done that include the MRI of the orbit and the brain, as well as the angiography of the whole body, all of which were normal of this aspect so far. Okay, so additional testing was done. The patient does have the finding that follows. So far, all the testing on negative for any type of infections or any type of autoimmune diseases. Is there another test, let's say another test for infection that one can expect here? Okay, so this is a very unusual case here. It's very, but certain part of the world it would not. Can anyone think of any type of other infection? I'm sorry?
No, this is not CMV.
This is not CMV from this aspect. So the test that we did not suspect carefully in here is a test for dengue fever. Okay, so this is the IgM for dengue was positive in this case, and this was done after a while when we thought about it and we debate back and forth. We get some help people locally as well to try to figure this out in this aspect. So this patient is IgM positive for dengue fever. The fundus autofluorescence 1 month after presentation in that aspect has improved, and in that the visual acuity also remarkably improved as well with this aspect. And so, but then here is the fluorescein, and this is the reason why the fluorescein was impressive in there. You can see along the posterior pole and along the both arcade, the type of perivascular whitening that you see there around the foveal center. And this type of finding, just 1 month after we treat with this aspect from there, same thing, both the right eye and the left eye for this aspect from there. Okay, so is this typical or atypical finding of dengue fever from this aspect? So this is actually a little bit common in this aspect from there. Also coupled by the fact that they have very poor rod response. This was done in India from this aspect from here. So based on this finding, this is a description of so-called pigmentary perivenous retinochoroidopathy secondary to inflammation, not to the infectious component caused by dengue fever here from this part. So here is more or less, and that's the reason why they respond somewhat to, they respond actually well to the high dose steroid treatment that was given to this patient, and we'll go over quickly now. So this is the type of thing that has been described before. This is a group from Singapore who has described this as the ocular manifestation of dengue fever, of this coming out from this aspect. And as you can see in this photograph, this paper come out ophthalmology of the finding along the posterior pole with that type of periveneal sheathing that we saw in there. This time. So in this case, dengue fever is a mosquito-borne and a viral infection that appear in here, and can lead to lethal complication called severe dengue that we do. The global incidence has actually grown in recent decades upward now there, and it's found in the tropical and subtropical climate worldwide in this area here. So it's transmitted by a mosquito. That's what I've learned. I was searching about this case here. Mosquito that mainly of the species Aedes aegypti there that you see this aspect. And so this mosquito also transmit yellow fever and Zika infections as well. The main thing to treat this body is just like some of the other viral infection that we face right now, to deal a lot with the aspect of sort of like conservative maintenance, just make sure the patient is being well hydrated and very aggressive treating and any inflammation we see. So in this case, the fluid body volume was maintained with a lot of IV fluid. The patient also was given these steroid as well to maintain that. And fortunately, he in this case did well from that. But I share with you those two cases here to illustrate that many times things are not black and white in this case, and these are very difficult cases that we are managing on a regular basis, whether it's in Boston, in New York, or in California, or anywhere in the world. Most people don't just come in to tell you that they have sarcoid or they have lupus, something that we can manage. A lot of time we have to do a lot of the digging out to find the things aspect there. So that's sort of like the conclusion I might share with you here. Any comment from any colleagues?
Kwan, this is Sanjay. I would just say that this is a great case. You know, a lot of these, just because of travel patterns, obviously things have changed a little bit since COVID took place, but a lot of these diseases that we're used to seeing or hearing about in other countries or outside, away from the typical geographic location, we're finding that those are occurring because of travel patterns. We're seeing more of those diseases elsewhere. So for instance, chikungunya, when it first was written about in India, or when we were seeing more cases in India, we began to see a new epicenter in the Caribbean, maybe about 7 or 8 years ago. And so we were seeing a lot of cases in New York. So I think it's one of those things that you have to definitely keep in mind in these situations where most of your routine testing is negative.
Yes, I fully agree with that as well too, and definitely there. And so, Dr. Foster, about a year ago, I think the book, no, actually the book came out already. It's a handbook. It's sort of like a curbside for uveitis. This is from the team in Boston that Dr. Foster did, and in it they describe some of the some of the key point to how to manage or diagnose some of these. And this was definitely on there as well. Chikungunya here and Zika and that type of thing. So we should keep this in mind. And like I say, it's quite difficult, but it's also quite challenging and quite interesting as well. So if we put our mind together, we'll be able to do it quite nicely. So any question from anyone else? It certainly have been a great time spending time with you. I'd like definitely to thank our faculty, Dr. Foster, Dr. Chu, Dr. Kedar, and Dr. Sepa very much for helping to contribute to this. My first time giving a course, helping with a course online like this, but certainly seems to work out from different parts here. And I wish everyone much success with this. The faculty on this course we are on can be easily found on the internet there. So if you have any cases that are difficult challenges, you can also write to us. Many of us do receive email from colleagues, and we try our best to share. I know if you write to the Uveitis Foundation where Dr. Foster is, they always respond, because patient told me that he respond very nicely. You can find, this morning I share my email already in the chat that you can get there. Dr. Kedar again is at UC Irvine, so you go to website there, you will see him. Dr. David Chu is also at the website for the Rutger group, so you can find us there. Dr. Sepa is at I on the Stanford website, so you can find us, and if there's any question that we can ever help, we cannot promise we can help, but we will do everything we can. Any testimony, Dr. Foster, the last word from you?
No, I don't have the last word, Kwan. I think you do, but I've enjoyed participating very much. Thank you so much.
Thank you. Sanjay and David, anything from you?
No, likewise. Thank you, Kwan. This is really, really an excellent opportunity. I appreciate it.
Yes.
Yeah, thanks, Quan.
Thank you, everyone, and have a wonderful day. Now you can leave and go home. Dr. Truss, I know it's late for you now. It's only 5:30. Daddy, we rest, and we hope to see each other. I was going to say, let's hope to see each other in Las Vegas, but as we know, that one is also being canceled already. So I don't know when is the next one that I will be able to travel. All I know is my status within United Airlines has dropped down to the lowest level possible over this past year now. And so, but best of luck to everyone in there, whether you're in practice or in training, and we look forward to seeing you again. Thank you, everyone. Goodbye. Bye-bye.
Thank you, everyone. Thank you, Dr. Nguyen, and all the lovely UVI speakers.